I'm very happy to have a public health expert with us. Hello, everybody. Good to be back. Right now, we have with us Dr. Varun Manhas. Let's listen to him. He's an expert after all. Over to you, Varun. Please go ahead.
Many thanks, Dr. Mathur, for having me on your YouTube podcast. It's a privilege to be here, and I have a presentation prepared, which I'll be sharing with the audience. So before I actually delve into the presentation, I'll give a brief introduction about myself. So my name is Dr. Varun Manhas. I work as an Associate Director of Public Health Programs here at One Health Trust based in Bangalore in India. I've had prior experience working for PATH and CHAI, Clinton Health Access Initiative, the other two major public health organizations in the world, both based in the US. By education, I'm an engineer. I did my engineering degree from India, followed by a master's from University of Oxford, MPhil from University of Cambridge, and then a PhD in biomechanical computational mechanics from KU Leuven in Belgium. I started my career as an academic, then got into strategy consulting in London. And just before the pandemic, I got back to India and got into public health consulting. So yeah, so topic of interest today is National Medical Oxygen Grid. We've been working on this for past 2 years.
Could you tell us what it is? Because even I don't know what it is.
Yeah, National Medical Oxygen Grid is a state-of-the-art IT platform which has been developed to monitor and track oxygen supply, consumption, manufacturing across the country.
Okay.
So before we actually delve into the platform itself, I'll start with the medical oxygen ecosystem that exists in India and the supply chain challenges that the country faced during the pandemic, followed by what steps the government of India took during and post-COVID-19 to strengthen the healthcare systems, as well as coming to the question, why we need National Medical Oxygen Grid. I'll give a brief introduction on it, and then I'll be comparing it with the data systems. So National Medical Oxygen Grid is a data system, an IT platform that was developed. And I'll be comparing it with existing platforms that were actually developed in the war-footing effort during the pandemic by Indian government. So there are two platforms mentioned here, ODAS and OCMS. I'll give details on this later on. And then finally, we've done the implementation across few states. I'll give the end user feedback that we received and the interest from other state governments in India we received for implementation. And then finally, I'll close the presentation with the implementation strategy of NMOG, which has been developed by One Health Trust. And this implementation strategy is not only for the states in the country, but also across all the LMICs that are struggling till date on managing their data systems for managing or developing data systems for oxygen supply chain.
You used the term there, LMICs. Could you just tell us what it is?
So LMICs basically stand for low and middle income countries. So any country that is developing or underdeveloped, basically countries in Africa and Southeast Asia and South Asia.
Okay, good. All right, let's continue.
Yeah. So basically to give you an overview of a medical oxygen ecosystem. So in a healthcare facility, there are these 5 pillars that you see on the screen. The first one being the source of oxygen that is basically required to ensure that there is adequate infrastructure for medical oxygen therapy in the hospital. So in sources, you have 4 different sources, LMO tanks, PSA, VSA plants, gaseous cylinders, and concentrators. I'll be delving deeper into these sources in my next slide. Then once you have actually sorted out a source of oxygen in a hospital, you need to figure out the distribution network. And some of these sources actually require medical gas pipeline system, which is the MGPS mentioned here, to deliver the oxygen from the source to the patient bedside. And then there are manifold rooms, which are basically running on gaseous cylinders that are also delivering medical oxygen from the room to the patient bedside through the patient from oxygen outlets.
And that L in front of LMO is what? Liquid?
Yes, liquid medical oxygen.
Right.
So again, as I mentioned, I will be delving into delving deeper into these sort of sources in my next slide.
Just for the ordinary person. So oxygen there is kept as a liquid. It's not yet gaseous, right?
Yes. Yes.
Storing gaseous would be very hard, take up a lot of space. So liquid is easy.
Yes, that's
right. Okay.
yes.
It's costly,
so liquid is a bulk storage. Yes, it's a bulk storage. You can actually have almost about 1,200 cylinders in a space of 1,200 gaseous cylinders equivalent oxygen in basically about 3 by 5 meters sort of space.
Yeah.
Whereas if you need 1,200 cylinders to store, you can imagine the size of the room and the space that is required.
Yeah.
So yeah.
Go ahead, please. Yeah.
So yeah, once you've figured out the source, you've actually got the patient, you've got the oxygen to the patient bedside. Before the oxygen is delivered to the patient, you require regulation and conditioning devices.
Yeah.
So regulation and conditioning basically helps you in controlling the pressure, flow rates, as well as the purity of oxygen. So there are pressure regulators which will help you control, because the patient out the pressure at the oxygen outlet next to the patient bedside is about 3 bar, which can deliver up to 300 LPM. But we are not delivering 300 LPM liters per minute flow rate to the patient. We are delivering somewhere about 40 to 60 at max. So you need to taper it down. So you need pressure regulators for that. You need flow rates, flow meters to control the flow. You need humidifiers, which is basically to moisten the air before it's delivered to the patient, so that the patient does not feel uneasy because the air is cold. And when you deliver cold air to the patient, it can actually dry your mucosal membrane in the nose, and it can cause discomfort to the patient. Then you have CPAP and BiPAP machines. They're basically sort of ventilators which help you control flow rates and pressure delivered to the patients, along with the HFNCs, which is again high flow nasal cannula systems. Basically, in layman terms, these are sort of devices that you require to deliver high flow rates to the patient in a controlled manner. Then once you've figured out regulation and conditioning devices, you actually need delivery devices, basically, which are the masks. And based on the type of mask here, multiple different sort of masks are listed: nasal catheter, nasal cannula, simple face mask, Hudson mask, Venturi mask. So based on the type of flow rate and the purity of oxygen you want the patient to have, you will choose a mask. So once that is done, then you also need to monitor the oxygen therapy. So you have devices for that. You have pulse oximeters, you have ABG machines. ABG basically stands for arterial blood gas analyzers. And then you have patient monitors to monitor the vital signs of the patient, such as heart rate, pulse rate, and respiratory rate, etc., etc. So if at all you want to deliver oxygen therapy safely and effectively to the patients, you need these 5 pillars. In addition to this, you need human resource, basically trained specialists, ICU specialists such as anesthesiologists. You need nurses and technical staff such as biomedical engineers, technicians, and operators to operate and manage these equipment. If you do not have any of these sort of verticals or sort of sources or infrastructure not available in the hospital, it's going to be very difficult, or it's going to be almost impossible for a hospital to deliver oxygen therapy safely and effectively to a patient. So you need to have all the equipment in the right quantity as well as in the right quality to deliver oxygen therapy safely and effectively. So now we've discovered the oxygen ecosystem in a healthcare facility in India. Let's delve into the oxygen supply chain. What different sources of oxygen exist? So here you see there are 4 different sources of oxygen: cryogenic or liquid medical oxygen manufacturers. Then you have air separation units. You have then PSA and VSA plants. PSA basically stands for pressure swing adsorption. VSA basically stands for vacuum swing adsorption. And then you have concentrators. So cryogenic liquid medical oxygen manufacturers, they're huge LMO plants. They actually have a capacity of about 100 to 200 metric tons per day. These are the plants that actually supply industrial oxygen. Industrial oxygen to industries that require oxygen, such as metal refining, or mining, or pharmaceutical or cement factories that require to have sort of furnaces that operate over 1,000 degrees Celsius. So they actually manufacture oxygen for industries, but then they spare some sort of their manufactured oxygen for medical supply, which is somewhere between 10 to 15%. So they manufacture the oxygen using cryogenic distillation process, where the oxygen is, the ambient air is basically cooled down to minus 183 degrees Celsius, which is the boiling point of oxygen. That is where oxygen basically separates from nitrogen, because you have 78% nitrogen and 21% oxygen in the air. And that's where then you store the oxygen below minus 183 degrees Celsius, because that's the boiling point of oxygen, liquid oxygen. So, and then you can supply oxygen directly to the hospitals that have LMO tanks, liquid medical oxygen tanks, or they supply oxygen to the LMO-based refillers. Then these refillers fill gaseous cylinders. They either supply to the retailers or directly to the facilities. So this is one supply chain for liquid medical oxygen manufacturers. As I mentioned, these plants can take about 3 years to install and commission. They can cost up to $10 to $15 million. So Indian government during the pandemic could not install these plants, because it would have taken 3 years and it would have taken a lot of investment.
Yeah.
Then you have ASUs. ASUs are like They again operate on cryogenic distillation technology. Their capacity is lower, up to about 5 to 10 metric tons per day. And their investment cost is about maximum up to $1 million. And again, they actually manufacture oxygen in liquid form, but they do not store in liquid form. They directly refill cylinders in gaseous form.
Okay.
So they supply oxygen either to the retailers or directly to the facilities, basically the healthcare facilities. Then you have PSA and VSA plants. These are the on-site, on-demand generation units, which have been installed during the pandemic. Prior to the pandemic, there were not many PSA plants installed or VSA plants installed in public health facilities in the country. Maybe some private hospitals did have them, but public health hospitals, very limited, or probably almost below 1% of the facilities would have had these PSA plants. And then you have concentrators. They also operate on PSA technology. So here in PSA plants, again, the ambient air is compressed, and then you're using the adsorption technology. You actually separate the nitrogen from oxygen, and then oxygen is further purified, and it's then delivered to the patients. Similarly, concentrators, they're small PSA plants. So PSA plants capacity can vary from 30 liters per minute to about 3,200 LPM, liters per minute. In metric tons, the capacity could be somewhere around 0.2 metric tons to about 5 metric tons per day. Whereas concentrators, everyone is aware, they have 3 to 4 different variants, 3 LPM, 5 LPM, 8 LPM, and 10 LPM. But now in the market, you also have concentrators that are all actually supplying oxygen at 15 LPM. And the cost of procurement for concentrators in India is somewhere around 150,000 rupees to 200,000 rupees. So before we go into the next slide, I just want to sort of differentiate between, want to provide to the audience what is the difference between medical oxygen and industrial oxygen. Is it actually manufactured by different companies or different manufacturers, or it's manufactured by, as I mentioned, it's basically manufactured by the same manufacturer. There are additional checks put in place for medical oxygen use so that the oxygen that is being delivered to the hospitals for patient oxygen therapy, it's basically safe. So what are the 3 different checks? First, the manufacturer has to ensure that the purity of oxygen is 90% and above. Second, it is free from impurities such as microorganisms, which basically includes bacteria, viruses, and fungus. Then it has to be free from contaminants such as dust particles, carbon particles, and oil particles. And the third important point is it has to be stored and transported in medical oxygen equipment or medical grade oxygen equipment. For example, medical oxygen cylinder in India is color-coded as white shoulder and black body, whereas industrial oxygen cylinder is color-coded as completely black. So that's how you differentiate between medical oxygen equipment or industrial oxygen equipment.
Okay.
So now further
by the way, I saw in a footnote in the previous that the concentrators are only 82%.
Yeah. So concentrators are basically for long-term oxygen therapy. So the concentrators were actually not designed for hospital use. They're basically designed for home care use. And you cannot classify them as medical oxygen sort of equipment. I mean, the oxygen delivered from concentrators is not medical grade as per the definition because it's 82%. But then, patients never actually get 90% and above. Very rarely they actually get 99% purity oxygen for therapy. You actually have to blend it. You have to drop the purity to about 40 to 60%, which is a typical purity rate. So concentrators are basically for patients who are actually on long-term oxygen therapy and they do not need hospitalization. These patients actually just stay at home, and on daily basis, about 3 to 4 hours a day, they actually switch on the concentrators, take 83% pure oxygen, feel better, and then continue the oxygen therapy on the following day. So that's how it is done.
So it's not, it's a very different system that we are looking at here.
Yes. So concentrators in the hospitals as well, they can actually help you save oxygen. So whenever you're starting oxygen therapy or weaning off patient from oxygen therapy, you do not require high purity. So you can start with low purity and low flow rates. And then based on how the patient is responding, the clinician can take a decision whether the patient has to be put on high flow rates and high purity. Then you can actually change the source of oxygen.
All right.
And they're on-site and on-demand generation unit as well. You need electricity to power them, and you don't have to be dependent on third-party vendors. So it basically helps you save oxygen. If at all you're using your cylinders for weaning off or starting oxygen therapy, then of course your cylinders have to be refilled. And if at all you're going through a pandemic, how are you going to get them refilled? So concentrators can come handy there.
Okay.
So, but the way they've been designed were mainly basically for home care use.
Okay.
So the supply chain challenges in India, there were four major problems. Here you can see the first problem was problem of production. We only had LMO manufacturing plants. So pre-COVID-19, 99% of the oxygen supply actually came from liquid medical oxygen manufacturers. As I mentioned, there were hardly any PSA plants in the country. And liquid medical oxygen supplies either supplied oxygen directly to the hospitals that had LMO tanks to store them, or to the refillers who could actually convert the liquid oxygen to the gases. And here you see on the map, the blue states, they're heavily industrialized states in the country. So that's where all the LMO manufacturers are based. So the distribution of LMO manufacturers in the country was not uniform. So there was a problem of production, and the demand actually increased quite a bit. So I'll share what the demand was pre-COVID and during COVID in the first wave and the second wave. So we struggled to meet the demand basically due to the lack of production facilities. Then you had the problem of transportation. So liquid oxygen requires specialized tankers that actually can sort of move this liquid oxygen, which is at minus 183 degrees Celsius. At the peak, Indian government had access to about 1,200 tankers, but whereas our demand to move the oxygen oxygen tankers to move the oxygen was about 2,000 tankers. Indian government did take sort of steps to sort of, convert liquid argon and liquid nitrogen tankers. And the other problem was, imagine if demand in Jammu and Kashmir increased quite a bit, and the tankers had to move from, let's say, Chhattisgarh all the way to Jammu and Kashmir. It would take about 5 to 7 days for the tanker to go and come back. And there is a speed limit as well on the fill tanker. This tanker is not allowed to drive, the driver of the tanker is not allowed to drive the tanker at a greater speed than 30 kilometers per hour. So you're traveling over distances about 1,000 kilometers, and then you have a speed limit of about 25 to 30 kilometers per hour. So imagine the turnaround time, which would be about 5 to 7 days. Then you have the problem of storage. So liquid medical oxygen tanks were only at government medical colleges before the pandemic, and district hospitals or sub-district hospitals did not have liquid medical oxygen tanks. So even if the production capacity of India was adequate, and even if the transportation capacity of liquid oxygen was adequate, we would still not be able to supply them because there were not enough storage tanks at the facilities that were delivering oxygen therapy. Then there were other challenges related to pricing, hoarding of concentrators and cylinders. So these are the four major supply chain challenges the country faced.
Okay.
So all was not sad during the COVID-19 pandemic. Indian government took multiple steps. So here I will just briefly touch upon these 6 major points. First, we enhanced our surveillance and diagnostics. Multiple RT-PCR labs were set up, collection centers were set up. Even post-COVID-19, we are setting up about 700 integrated public health laboratories, along with 600 block public health units, which are again laboratories at block level. Then we had the most successful immunization and vaccination program, which was run for free of cost for the citizens. And this immunization and vaccination program, because it helped reducing the severity of the symptoms during COVID-19, which I think further reduced the demand of oxygen because there was less hospitalization due to vaccinations. Then the government also increased the hospital bed and equipment infrastructure. So multiple beds and multiple equipment were procured. Then medical oxygen supply chain, manufacturing capacity was enhanced. Investments have been promoted. A lot of defunct manufacturing units were sort of revived. Storage capacity has been increased as well. As you can see, 958 LMO tanks are being set up across various district hospitals in the country. A lot of cylinders were procured as well to enhance storage capacity. Then transportation, new LMO tankers were procured, as well as, we used the services of Indian Railways and Indian Air Force to cut down the turnaround time from 5 to 7 days to about 1 to 2 days. And then other sort of decisions are also taken about using technology such as IoT devices, Internet of Things devices, to monitor the demand, supply, and consumption happening through LMO tanks as well as PSA plants. Then the data systems. So my presentation today is going to be focusing on data systems. Multiple data systems were developed, such as ODTS, Oxygen Demand Tracking System, oxygen demand aggregation system, and OxyCare management information system. Then additional policies and guidelines and capacity building efforts were made. A lot of funding, finance packages were released, PM Care Fund, ECRP funds, and then a lot of technical guidelines on rational use of oxygen, installation and commissioning of oxygen equipment, as well as, a lot of helpline numbers were set up. So yeah, Indian government was not idle during the pandemic. They were very active and took very, very important steps to ensure that the government was doing everything that it could do to save human lives. So what is the need for National Medical Oxygen Grid? As I sort of briefly mentioned, it is basically state-of-the-art IT platform that has been developed to sort of track, monitor consumption, supply, manufacturing, and stock of oxygen across healthcare facilities in the country. So demand of demand of oxygen during COVID-19, pre-COVID-19, it was about 700 metric tons, whereas the manufacturing capacity of the country was about 10,000 to 12,000 metric tons per day. In the first wave, which was about September 2020, the demand increased about four and a half times to 3,200 metric tons. So we did find we were not struggling with the supply chain challenges. But in the second wave, which was around May 2021, the demand further increased by 4 times to about 12,000 metric tons per day. That is where the struggle began. So Indian government during the pandemic developed multiple systems such as ODTS, ODAS, and OCMS. These systems actually proved to be invaluable assets and helped the sort of administrators and facilities to make meaningful decisions on demand supply decisions. Whereas with hindsight, we realized there are a lot of limitations with these systems. First, they were not integrated with each other. They were not capturing all assets. Some systems only captured cylinders and concentrators, whereas other assets only captured LMO tanks. Then there was another sort of system that only captured PSA plants. So they were not integrated with each other. People had to do multiple data entries on different platforms so that the government could get complete picture. Then there were no dashboards.
Let me just ask a question.
Sure.
Who operates these systems? Who owns them? Who operates them? Who designs them and who developed them? These are all questions perhaps outside, but I'm interested.
So these systems are actually developed by the Indian government, and they were maintained by the Indian government. And they were so these systems were mainly designed for hospitals to use. So they created a user ID per hospital to do the data entry. So hospital had to sort of report their demand, supply, and consumption in metric tons on daily basis. So they had to enter data on daily basis so that based on that, the government could take decisions on how the distribution of oxygen is going to happen across the states. And then the state governments were taking decisions on how the distribution is going to happen across districts within their states.
Software was done. The software was developed by Indian software companies. So, I mean, they were.
Yes.
Yes.
Okay. So it was basically developed by CDAC. CDAC is a government entity that actually develops a lot of HMIS systems for healthcare facilities.
I see. So even not outsourced to private companies, but CDAC could do it.
Yeah, CDAC could do it. Yes, absolutely.
Okay, wonderful. All right. That's good to know. It's very, very heartening to know that it could be, because then it's done quicker. Yeah. So anyway, let's continue.
Yeah. And then these systems are mostly web portals and there were no phone apps. Some of them actually had a phone app, but not all of them. And there was no way of entering data in offline mode. Sometimes you have internet availability, sometimes you do not. So let's say if you do not have a internet availability for the day, you could not submit data. And then if you see the graphical user interface for these sort of platforms, they were not user-friendly. Yeah. So looking at all these issues, we actually came up with designing this new platform, which is called National Medical Oxygen Grid. So this grid actually links both the demand side. So basically you have the hospitals that will enter data as well as the supply side. So the suppliers are actually supplying data, which is going to be fed into the system. Then based on that, multiple analysis is going to be done, and there are going to be dashboards available for different sort of users. So you have suppliers, so you have service providers such as hospitals. There'll be a dashboard available for them to make decisions. Then there'll be a dashboard available for district, state administrators and national administrators. Yeah. Then there's also a dashboard for suppliers as well. So what sort of data were we collecting? So there was basically one-time activity for the demand side, basically healthcare facilities where they had to enter data on their assets. Then on daily basis, they had to enter 3 different data entry fields, which first one was basically bed occupancy. So we've defined different sort of beds, about 7 different types beds, like ICU beds, high dependency unit beds, uh, pediatric intensive care unit beds, neonatal intensive care unit beds, then operation theater beds. So yeah, multiple sort of beds. So they had to enter data on daily basis. What is the occupancy of these beds? Then also, we were moving away from COVID-19 demand of oxygen. We've also defined 22 different conditions that require oxygen therapy, such as COPD, pneumonia, asthma, myocardial infarction, etc., etc. So we're
Yeah.
also capturing disease specification load as well. And
Yeah.
then, of course, the oxygen stock, which is basically the amount of oxygen you've manufactured on the day, amount of
Yeah.
oxygen you've received from your third-party vendors, and the amount of oxygen you've consumed. So
Mm.
that is the data entry. And then suppliers also have to report on how much oxygen they apply to each supply to each facility
Yeah.
within the jurisdiction. So, and then based on the data that has been collected, a lot of analysis is being done. We have open source tools as well within the system. First one is basically a knowledge product tool, which basically gives you access to all the guidelines, be it clinical or technical, training videos, posters, etc., that has been sort of developed by governments, that has been developed that have been developed by public health organizations such as WHO, UNICEF, Clinton Health Access Initiative, JPIGO, PATH, One Health Trust, and also a lot of planning tools for ensuring that you plan your oxygen sources and oxygen demand well in advance. In addition to this, there is another sort of tool which is open source, which is giving you a checklist of oxygen commodities and consumables that are required for a facility to deliver oxygen therapy safely and effectively. Then you have demand predictive tool. Based on your bed occupancy, it will tell you what your demand would be in the future. So here we're only predicting for next 7 days, and also demand of your oxygen based on your bed occupancy.
Right.
Similarly, we've also designed a tool which will actually help you use your oxygen sources optimally, because now all the hospitals have 4 different sources of oxygen available: LMO, liquid medical oxygen, you have gaseous cylinders, and then you have PSA plants, and then you have concentrators. So based on your demand, you can use the cost analysis tool. You can actually figure out what is the most optimal source of oxygen, or what is the most cost-effective source of oxygen for you for that particular day based on the demand you have. Then finally, you have oxygen unit conversion tool. This was very important because during the pandemic, Indian government expected all the hospitals to report their demand, supply, and consumption in metric tons. Metric ton is basically a weight measure.
Yeah.
Whereas oxygen is gas, so basically you deal in liters or meter cube, which is a
Right.
unit of volume.
Right. Right.
And then you have liquid oxygen, which is dealing in kiloliters. And then how you convert from liquid to gaseous oxygen, because that's a different sort of physics. So we have actually designed this tool where you can convert one unit to another seamlessly. So if at all you want to convert your kiloliters into metric tons, you can easily convert. If you want to convert your liter per minute to metric tons or meter cube to metric tons. So this is basically to facilitate that sort of conversion, because you need to require a density for both liquid and gaseous oxygen to convert from mass to volume or volume to mass. So one of the major challenges we faced in the previous data system was data entry, because a lot of hospitals were struggling. Because imagine, and this was mainly because if you have a tertiary care hospital such as AIIMS, which is a huge hospital, can have about 4,000 beds, could be spread over acres, would have multiple units, multiple wards, n number of beds, and n number of oxygen assets. They may have 10 PSA plants, 4 LMO tanks, and 500 concentrators, and maybe about 1,500 cylinders. But the previous data systems only allowed one user profile or user credential per facility to enter data. So that person had to be responsible for collecting the data, ensuring that it is accurate, validating it, and then entering it. Imagine the amount of burden that person would have. He would be spending almost 24 hours a day and still would not have access to accurate data.
Right.
And there would be a lot of inaccuracy. So we've actually come up with this interesting concept of master and satellite operators. So what happens in master and satellite? Master is basically a data entry or a personnel within the facility who could be a senior person who would not do any data entry, but would only validate the data entry that is being done by satellites. He would create multiple satellite operators within a facility. We've not set a limit to the number of satellite operators that can be created within a facility. It could be 100, it could be 500. And each operator could be given responsibility of one asset. That's it. One could only respond or enter information on PSA plant 1. The other could only enter information on PSA plant 2. The third could be entering information on LMO tank 1, LMO tank 2. And then similarly for bed occupancy as well, you can have one staff nurse entering only information on one unit, one ward, or one ICU. And then they can also enter information on only one disease type. Sometimes you have a disease specific ward, so they can only enter information on that particular disease. So when all these satellite operators enter the information, the master gets notification that everyone's submitted the data, and then he validates it and submits it. So this feature actually reduces the burden of data entry. So you can have 100 people entering the data rather than one person responsible for collection, responsible for validation, and responsible for data set. Secondly, we've created not only the web portal, we've also created both Android and iOS app. India has got the largest, I think one of the largest users of smartphones in the country. About 900 million people use smartphones. Everyone in India has a smartphone. So
Yeah.
all these operators also have smartphones. They don't require access to desktops or laptops to enter data.
No.
The beauty of smartphones is you can also enter data in offline mode as well, if at all you do not have active internet. Let's say if you want to enter data through a web portal, you probably need active internet to access the web portal, like the website. Whereas the app could be accessed in offline mode as well. The only limitation there is before midnight, they just need to have internet access for a few seconds so that the data can be uploaded to the main server. Otherwise, the submission of the data will not happen, and the end will be blank for that particular day. So I think these two specific efforts, ensuring there is Android and iOS app, and then the concept of master and satellite operators will ensure, and we've experienced it, that the data entry is happening much more regularly than if you compare with other data systems like OCMS or ODAS, which I've briefly mentioned.
Just a minor question. Isn't cellular access enough? Why do they need Wi-Fi?
No, cellular access is enough. You don't need Wi-Fi. But sometimes, let's say, right now, we are only talking about tertiary hospitals, which are basically in big cities, right? So our plan is to go all the way to primary health centers as well. Because oxygen therapy starts at primary health centers. The newborn children, the new mothers, sometimes there are some complications during delivery. So they require oxygen therapy. So we want to track the consumption and supply of oxygen at primary health centers, and they're all in rural settings, rural part of it. So there, sometimes you may not have access to the Wi-Fi. And that's why we require a phone app that can be utilized.
So cellular, they can upload with cellular.
Yes, absolutely.
Cellular, everybody has, cellular hardly fails, right?
Yes,
the Wi-Fi that's missing, cellular is there. Okay, good. Sorry to interrupt. Let's go ahead.
So this is basically, you can access the web portal with this link called auctiongrid.in. And these are the basically screenshots. And this is just an overview. The portal itself is in a lot more detail. This is how the graphical user interface. So first here on the left, you can see the login page. Here, you can see the 5 open source tools. So you don't need login credentials to access these tools. Anyone can just click on the link and then go there. And you use these sort of demand predictive tools, cost analysis tool, and unit conversion tools, and the repository on knowledge products, as well as the checklist for oxygen therapies, commodities, and consumables. This is the phone app. This is how it looks. We have, as I mentioned, both Android and iOS. So each feature and function that is available on web portal is also accessible through phone app as well. So people do not need a web portal to sort of do the data entry or to go through the dashboards and see the analytics that is being performed based on the data that has been collected. So when I compare ODAS and OCMS, we can see these sort of important differences. First, our user interface is very intuitive. And as I mentioned, we've created the master satellite user concept and the personalized UI. I cannot actually show you how it's personalized. So basically what is that you can actually pick and choose what features in the portal you want to see on your dashboard. You can select and unselect. So that's personalization. And then you have phone app and web portal. In addition to this, we are not only capturing COVID-19 demand of oxygen. As I mentioned, we're capturing a demand of oxygen for 22 other disease conditions. Then we also have order placing and management from the supply side. So like you use Amazon to place your order, you can place order for your oxygen as well. And your supplier will get a notification on his app that the order has been placed. He can accept, reject, and then also report and dispatch, and also the estimated arrival times of those orders. So that can be all tracked to the app. Then you have your predictive analysis of auction demand, bed demand, and also based on your historical patient-specific caseload, you can actually predict what your future sort of caseload is going to be. Then we have another feature called decision analytics. This is very important feature. So what this feature does is, let's say if you're running out of your auction in the next 7 days, it will automatically activate a feature where you can actually see the 10 nearby facilities that have auction available, and they can share that auction with you. And you can call them and ask them to share these assets.
When you say
All,
share, there must be a price. Who's setting the price?
no, because these are all government hospitals, right?
Okay.
So it's all transaction happening from one hospital to another. So there will be no price there.
Okay.
Also, let's say if a hospital is running out of their beds, so they can actually redirect these patients to a hospital, uh, which is within, which is nearby, and they'll be able to see the availability of beds in that hospital as well.
Right.
So they can redirect these patients.
Okay.
So
There is no price, but you had mentioned hoarding earlier. What is happening with hoarding here?
So hoarding basically happens by private players. So this is all. So let's say if I'm a hospital A and I'm running out of oxygen, I can see on my platform there is a hospital B, which is a government hospital, which is about 25 kilometers away, and I can see what their movable oxygen assets are. So movable oxygen assets would be gaseous cylinders or concentrators. You cannot move LMO tanks. You cannot move PSA plants. So then you can actually call them and ask them, would they be interested? And only those hospitals will show that are actually having their own 7-day future demand being met.
Right.
Otherwise, it will not show. Let's say if a hospital is going to run out of their demand in 2 days or their oxygen supply in 2 days, they'll not be showing to this particular hospital A. So only those hospitals will show that are actually having their oxygen demand being met for the next 7 days. And then you can ask them, and it's a request you can raise. Of course, they will have the opportunity to decline it, but of course, at least they have this opportunity to reach out to this nearby facility which will have available oxygen assets.
Yeah, I get it. Understood.
Then you have rational use of auction tool as well, which basically, based on bed occupancy, will tell you what your estimated consumption would be and what your actual consumption would be. You would be recording your actual consumption, and if at all the difference is too high, then it will actually probably give you a notification or will ask you to sort of do an audit in your hospital to ensure there are no leakages, no wastage happening. And then you have all the information being presented in a map-based data visualization tool for hospital administrators as well as district administrators and state administrators. So this tool will actually basically help you in asset management and asset allocation and reallocation. So what happens in India right now is, let's say if hospital A has a demand of new cylinders, like a government hospital, it'll just send a request to this district administrator or a state administrator that we need new cylinders. Can you procure them for us?
Yeah.
Now the hospital district administrator or state administrator can see using our platform that there is another district that has a lot of auction assets and does not have a high demand. So rather than procure new assets, they can say, okay, why not reallocate these assets to this another district where the demand of auction is going up? So that will actually help them optimize the procurement process as well and save money.
Right.
And then, of course, help and support. We have video tutorials for all the features and functions, how to use the platform. So that's another feature we have in comparison to the other two portals that were developed. Here you can see, so we've done the implementation across 3 different states as of now. So here you see pictures from UP and Karnataka, where our team actually went to different sort of hospitals, ranging from government medical colleges to district hospitals to sub-district hospitals to CHCs and PHCs. And we did a training for different sort of healthcare staff, ranging from anesthesiologists to pharmacists to hospital managers, staff nurses, biomedical engineers, biomedical technicians, equipment operators, etc., etc. So we've received testimonials as well. We've got good feedback from various sort of staff. App has been very well received, and they say it's the state of the art, the best that I've come across for auction management. And it's a novel tool, and will probably definitely encourage them to do data entry on daily basis. Similarly, we've also asked very specific questions, whether they found the new portal useful, how it was in comparison to the previous portals. And 80 to 85% of the response has been excellent, and the remaining 10% has been good to average. So yeah, we've received excellent feedback, and that has been sort of good motivation for us to sort of, slowly reach out to other states as well and expand to other geographies. So right now, the portal is being used in about 70 hospitals across the country, out of which 60 are actually tertiary care hospitals, mostly district hospitals. So about 51 district hospitals in the state of Madhya Pradesh are using it. Uh, we are next in line to sort of implement it in the state of Tamil Nadu. And then we are also in talks with Karnataka, Chhattisgarh, Odisha, Rajasthan, and few other states. We've also reached out to, WHO as well. They've also you've appreciated the tool. And we've also got an opportunity next month. There is a huge WHO meeting happening in Senegal, where we've been given opportunity to present this tool. And we're also sort of reaching out to other development partners such as Path and Chai, if at all they want to collaborate with us in implementing this tool, not only in India, but also across other geographies such as South Africa, Africa, and other countries in African continent, as well as Southeast Asia and South Asia. So what is our implementation strategy? So first, the value proposition. So this tool basically helps in
By the
pandemic
way, let
preparedness.
me pause you there. Congratulations. You've done a great job. I mean, I know it is very much in need in African countries. They would be really, some of them are not as large as India. So, the communication is not so important as in India, where, as you said, from Chhattisgarh to Jammu and Kashmir. But I think it's a very, very helpful tool. And I'm really very, very impressed by the way it has been thought out, the way it has been developed. It's actually, I usually have a comment to say, perhaps you could do this, but in this case, I'm speechless, which is a great, what should I say, a thing for me to say. I'm speechless. Okay, let's continue.
Thank you very much for those kind words. So yeah, so last 3 slides where I'll be discussing the implementation strategy. First, what is the value proposition for this particular tool that we've developed? It helps in pandemic preparedness. WHO predicts that there's going to be another pandemic around the corner where demand of oxygen is going to go up. So this tool has to be sort of implemented across countries, where when the demand goes up, you can actually sort of take decisions not only based on anecdotes, but also based on data back. You can do data back decision making. So this tool actually gives you predictive analysis, decision analysis. It helps you in supply mapping. It also gives a feature for order placements and tracking. Then, of course, it helps you in asset management. And we are capturing all the assets that are required for oxygen therapy. Not only for sources of oxygen we capture, we also capture the high flow delivery devices such as ventilators, CPAP, BiPAP machines, as well as high flow nasal cannula systems. Along with this, intensive capacity building tool is there. And while we're actually training the hospitals on utilization of or uptake of this tool, there'll be intensive capacity building happening both for clinical and technical personnel. Then the tool will actually help in policy building. Let's say if the tool has been used in the country for a year, you can actually see the demand fluctuations based on temperatures, climate change, etc. Because with climate change, you will have respiratory illnesses. The countries will be able to figure out, let's say, in the month of June and July, or in month of November and December, the demand of oxygen goes up, so they can do the planning well in advance. And it will also help in sort of not only focusing on COVID-19 demand of oxygen, but also focusing on 22 other conditions that require oxygen therapy. Then, of course, we are helping in optimal utilization of sources through our cost analysis of oxygen sources too. And the tool that has been presented here has also been published in a peer-reviewed journal in Indian Journal of Anesthesia. And it has been published by One Health Trust, with me as being the lead author, and in collaboration with IIT Delhi and AIIMS Hyderabad, as well as the government of Madhya Pradesh, who actually provide us the data for our analysis. Then we have rational use of oxygen. Again, before COVID-19, people thought that oxygen is like a free drug, and it's available in abundance. But we realized that it has to be rationally and judicially used. So we actually provide this tool for rational use of oxygen, and also help facilities prepare for audits if need be, to understand the wastage that is happening in those facilities. Then, of course, to make it more user-friendly, we've given the features of personalized GUI and user interactive interface. We have web as well as phone app, both Android and iOS versions. Then, of course, to ease the data entry, we've created this concept of master and satellite users, which will definitely support in reducing the burden as well as ensuring that the uptake and the implementation happens to the maximum. So what are the timelines? So how we actually go about implementing across states? So we probably take about a year, and this is how we divide the whole process into about 8 steps. So first of all, in step 1, which takes about 2 to 4 weeks, we engage with the state. We request them for a pilot where we sort of implement the tool. And this sort of implementation is also applicable to a country, not only to a state. So we request them to do a pilot in a few facilities, which could be about 6 to 10 facilities. And these facilities could be different sort of facilities. It could be tertiary care. It could be a mix of tertiary care, primary care, secondary care. We do the pilot, and then we prepare a pilot report. And based on the pilot feedback, we actually make modifications. In India, we do not have to make modifications because the healthcare system across states is very uniform. The terminology that is used for various sources and various infrastructure is very similar. Let's say if you're going to another country in Africa, we may have to do some sort of tweaking after there is a feedback that we receive from the pilot. Then the pilot report is submitted to the government. And then followed by that, we actually get permissions to scale up in the tertiary care facilities, which can take about 3 to 6 months, which is step 5 here. Then once that is done, we help in rebranding of the tool as per local requirements before we actually do the complete handover to the government there. And then also in step 7 and step 8, we actually start supporting them remotely in sort of, scaling up or, implementing this tool to other sort of facilities such as secondary care and tertiary care facilities. So this is basically, and we are happy to partner with any development organization such as, PATH, Chai, Japago, who would love to sort of work with us on implementation, not only in India, as I mentioned, but also across different other countries in Africa, as well as Southeast Asia and South Asia. Of course, the implementation would come at a cost. So we are not charging anything for the tool itself. It's free of cost. So procurement cost of an emoji IT platform is free of charge. However, there will be annual recurring cost for hosting iOS app. For the first year, we will be able to cover it, but then going forward for sustainability, the government will have to pay for this cost. And for hosting the app on iOS, it will cost about $99. So we've created 2 different costs for an Indian state and for another country. So it will be $99 for both. Then you have one-time cost for hosting Android app on Google Play Store, which is about $25. This is one-time cost. You don't have to pay it again. Then you have an annual estimated cost for customized web domain name. Right now, we're using the domain name as auctiongrid.in, but let's say the state says, no, we want auctiongrid.madhyapradesh.in or something of that sort. That can be customized, and that will have a recurring cost of about $45 per year. So let's say if at all you want to expand it to countries in Middle East or Africa, the tool will have to be translated to other languages such as French, Arabic, or even South America into Spanish. So in India, the tool will only remain in English, whereas if at all it's being translated to another language, it will cost one-time cost of $5,000 per language. Then you have maintenance IT costs, only if required by the state, which will be, if at all they want us to manage their portal going forward, that will be $10,000 per year, about $800 to $900 for the entire country. That's very, I think, cost effective. Then handholding and implementation support. So if One Health Trust team is providing this support remotely, it will be about $2,000 per month in India, whereas same it will be for other countries as well, because it's all remote support. And we expect the states or the countries to have at least 6-month remote support. So that'll be amounting to about at least $12,000 for the implementation. However, if they require in-person support, so in India, the cost would go up to about $6,000 per month, whereas abroad it can go up to about $8,000 per month. So if it's 6 months, it will be amounting to about $48,000. And in India, it'll be about $36,000. And then before these platforms are handed over to the government requires security certificates, ensuring that these portals are not stealing data, they're safe to be hosting on government-owned servers. So it will cost about $5,000 in India, and in Africa as well, I think the cost would be very similar. So overall, this will be the implementation cost. So one-time cost would be about $41,000, and the recurring cost would be $10,000. And if at all you require remote support, that cost in India would be about $17,000 to $18,000 for an Indian state.
Yeah.
And for a country would be about $22,000. So I think this is like a very cost-effective solution at a very sort of cost-effective price. As I mentioned, the procurement cost of the tool itself is zero. So if any partner who wants to work with us, could be a donor partner, could be sort of, implementation partner, we would be happy to collaborate and would look forward to hearing from anyone. Here, I have given my email address as well. So I would love to hear from anyone. And thank you very much, Dr. Mathur, once again. And I would be happy to take more questions as well and go deeper into the discussion. Thank you. Over to you.
Okay, could you shut off your screen share so that we can talk a bit better? Well, as I said, I'm in a very unusual situation. I'm speechless. All I can say is congratulations and well done. And really, it is the face of modern India, which is relevant for many other countries. Is relevant for many other countries. I mean, we have built up this expertise not overnight. Over many years, we have had set up the institutions. You may mention CDAC, you mention your own institution. We have the software. We have the ability to get it done. We have the ability to think it through. And congratulations. It's, as I said, is one of the faces of modern India that I'm hearing and listening to. And it's very impressive. So we can talk a little bit offline about various other things that I'm interested in. But for the moment, I don't have any questions. It's just, as I said, in short, one of the faces of modern India in public health, which is, of course, the pandemic really showed that the public health systems of most countries are not strong enough. And obviously, as you said, the government did a lot to build it, but obviously we aren't there. And what you're saying is that it's no use saying we aren't there, we have to get there. And this is a key part of getting there. And I'm sure that having built this tool, you aren't sitting back and saying, now we can relax for the next 5 years. You are thinking of something else to do, build similar tools or something similar, which would strengthen the ability of the public health system to actually deliver the services that the people need. I mean, the data is, of course, very important, but in the end, at the fingertip, the doc should be able to say, get me oxygen, right? And people say, yes, sir, we'll get it. Or yes, ma'am, whatever it is. Get me oxygen. This patient needs oxygen. That should be enough for the doc to say, and the system the gear should grind in the background, or the electron should flow, and the oxygen arrives. Or whatever it is that the patient needs, because we need that delivery. Okay? And since I'm getting old now, I'm more aware of these needs than when you're young. Because when you're young, you don't go to see the doc, but yes, I do go to see the doc. So we do know that the docs themselves don't know a damn thing. They only say, the patient needs this, okay? Now they don't know how to get it. They don't know where to get it. They don't know what to do. They can only say, do it. And somebody has to do it, okay? And the system behind that has to run well to meet what the doc prescribes. So this is one part of it. Hopefully we don't get another pandemic, but if we do, we are better ready than in the past. So thank you very much. Is there any final thing you would like to add?
No, I think because of course, the hope is that there's no pandemic around the corner, but then, we'll have to be prepared. And the preparation can only happen in the non-pandemic times. It cannot happen during the pandemic. So for example, this platform that we developed, we have to make the best of it, get used to it. We have to make it in our habit to, enter the data in these times. Imagine when we actually sort of start using these sort of platforms in non-pandemic times, when you actually face the challenge in the pandemic times, then it will come naturally to you and you will not feel burdened by sort of doing this sort of additional reporting.
Yeah.
So hoping that, with the collaborations going forward, we can sort of, rather than making it national medical oxygen grid in India, we actually help sort of, facilitate ensuring that every country, especially LMIC country, has a
Yeah.
grid, which is very similar to this, and we can help them develop.
Okay, good. As I said, this is the face of modern India. Let's end it here. And maybe we get back to you in a year to see what's happened, what's it's working, which are the countries you might have been able to get to. Let's end the recording here and we'll talk offline a bit, okay? So bye, everybody. I'll be back with an expert or a young person soon. Bye till then.